Well, thank you, everybody, for joining in this afternoon. I don't have any disclosures to make. I have no financial relationships to disclose and no label use or investigational use in my presentation. To start by some acknowledgements. As a breast pathologist, I am deeply grateful to all those researchers, scholars, and educators in breast pathology who have come before me and have strived over the years to establish criteria, reproducible criteria for breast lesions, and to recommend optimal patterns of practice for clinical management of the patients we care for. I think it's important to say this and acknowledge this because I love breast pathology and I love teaching breast pathology, but what I'm going to share with you today is really information information that I have learned over the years from presenters and really not a breast researcher on my own. This is information that I've gathered over the years and I've been able to learn and hopefully provide some of my wisdom and recommendations to you. So topics of this webinar are as listed as follows. I want to start by a talk on relation of specimen size and upgrade rates, and then talk about the importance of imaging and pathology correlations. Then going to shift gear a little bit and talk about selected diagnostic and management problems in breast pathology, about what we should include in our pathology report, and quality assurance in quality improvement in breast pathology. My learning objectives for you, the attendees, are threefold. First of all, to recognize the more common diagnostic dilemmas in breast core needle biopsy pathology, and hopefully after this presentation you'll have a consistent strategy that you will develop in your group practices regarding how to deal with these kinds of problems. And secondly, I hope that you will appreciate the importance of a multidisciplinary team-based approach to the safe, high-quality practice of breast pathology. This is really critically important in breast, and we'll talk about that a little bit later. Thirdly, I want to focus a little bit on quality assurance in breast surgical pathology practice and talk about the entire spectrum of quality assurance, including the pre-analytic, analytic, and post-analytic phases, with a specific focus on the importance of second review. Start with needle size. So what you get is based on what you receive. You can only make a diagnosis as good as the quality of the tissue that we receive. As pathologists, we know this very well. It's pretty important in breast pathology, essentially, that we get adequate tissue to look at. The traditional core biopsy gun is a 14-gauge gun. However, in many centers, vacuum-assisted devices are being used, and these are of a higher gauge, 11 gauge, or actually lower gauge, I guess. And you see that the rate of underestimation of the lesion will vary with the size of the tissue. In other words, the chance that the lesion will be worse on excision than is in the core, dependent upon, in extent, on the size of the core of the tissue that one receives. Example, atypical ductal hyperplasia and DCIS. With ADH, we know that with the 14-gauge needle, there have been studies that have shown that the upgrade rate can be as high as 60%. With the vacuum-assisted 11-gauge needle, it drops to about 20%. So for DCIS, a 14-gauge needle, the invasive carcinoma rate is approximately 20%, whereas it drops to 10% if one uses a larger 11-gauge vacuum-assisted needle. correlation. I think most of us have heard about the triple test, but I wonder how many of us truly use it. The triple test really, as it says, is really a combination of correlation of clinical, imaging, and pathology features. It's fairly standard practice now that if calcium is the reason for the biopsy, suspicious calcifications, they're generally confirmed by specimen radiographs. These are usually done by the radiologist, although in some settings they may be done by the pathologist if they have a specimen radiographic device, ideally done by the radiologist. This is an essential component of the quality assurance, the pre-analytic quality assurance procedure now, and should be done in every center doing stereotactic core needle biopsies. There should be some attempt to ensure that the lesion is being targeted by the radiologist or occasionally perhaps by a clinician, it's by core biopsy, there's some reconciliation. In other words, if it's for calcification or for a mass or an asymmetric density, then the pathologist needs to try and ensure that there is some correlation with one of those three or sometimes other types of lesions that are being identified. I regularly use the term concordance and discordance in my reports. I will say that the findings appear to be concordant with the radiologic or clinical impression, or I will say that there has to be a discordance between the radiologic and the pathologic finding, and that follow-up is recommended. And I think that that concept of concordance and discordance is an important one in breast core biopsy pathology. For discordant diagnoses, there has to be some attempt at reconciliation, and we'll talk about this later. I will specifically state in my reports that some sort of repeat core biopsy should be attempted, or some sort of final path correlation should be performed. I think it's important for pathologists to understand the reporting system that radiologists use. Many of you may be familiar with this, but it's on rare occasions, but we sometimes get Category 3 lesions. Usually those are fibroadenomas that they don't want to excise, but the patient wants some reassurance, and so sometimes we'll get Category 3. But for the most part, we will receive Category 4 or Category 5 lesions for biopsy. And important that you understand what this means if your report simply says BIRADS 4 or BIRADS 5. Sometimes the BIRADS 4 category is subcategorized into low, intermediate, or moderate, but this is of less importance than just understanding the overall general category. There are certain terminologies that are used by radiologists that are useful for the pathologist to know, and I specifically look for them in the reports. We get paper requisitions still with our specimens, and the radiologist will either write down what they think or submit with us a photocopy of their stereotactic core biopsy worksheet, and so that sometimes suffices. But there are certain buzzwords that are very important. Spiculated is one of them. When I see spiculated, I'm looking for invasive carcinoma. It's like cancer of the crab, those tentacles every direction. So spiculated is either invasive carcinoma or possibly a radial scar. And if I don't see invasive carcinoma, when they say spiculated, that's discordant. Similarly, if they say that there are pleomorphic calcifications present, then I'm looking for DCIS by and large. And if I don't see them, then I may do deepers or do their studies or issue a report that indicates that there's discordance. Ultrasound, generally they're looking for, usually you get told that there's either a circumscribed mass or an irregular mass, and an irregular mass, of course, is more suspicious. In our center, we don't have too much experience with MRI. We have some, but these are some of the terminologies that are used. We don't tend to get too much information on the MRI lesions, and so I don't have quite much experience with them. But certainly the MO and the ultrasound are the big ones. So the key diagnostic problems that we have in breast pathology are listed here, and these are the ones that, at least some of them, that I'm going to spend a little time talking about and with the management implications. So atypical ductal hyperplasia versus low-grade ductal carcinoma in situ. Generally, if there's high-grade cytology, then it's not a problem because high-grade cytology will trump the architecture. Motivation is often a challenge in small core biopsies, and trying to determine whether it's present or not is an important feature because it may or may not result in sentinel node. Well, it will result in a sentinel node biopsy if there is microinvasion. Solid pattern ductal carcinoma in situ, so the cells may, especially if low grade, mimic those of large carcinoma in situ, especially the so-called category B type cells. Tubular carcinoma versus benign tubular lesions. This could include various types of adenosis, microglandular adenosis, or sclerosing adenosis, or adenosis tumor, and sometimes radial scar comes into that differential. And then the various papillary lesions, trying to separate papilloma from atypical papilloma and papillary DCIS. We'll talk about this shortly. Benign papilloma in quotes, because this is terminology that I personally hate. Papilloma to me is by definition benign and doesn't need to be otherwise qualified, but there it is. It's understood by people and it's in the lexicon. Mucocele-like lesion, we'll talk about that, and similarly with the fibroadenoma versus benign Phyllodes tumor. What do you do? What should you do? These are just some of my suggestions of what to do with difficult problems. Just speaking, when findings are equivocal, the first thing is to try and overstretch yourself, overcommit with a diagnosis. In these kinds of cases, I find that a descriptive terminology is better. Papillary lesion, see comment, and then provide a differential diagnosis, or just tell them to doubt. Some things with fibroepithelial lesion, that sort of thing. Maybe better than trying to say that it's papillary carcinoma or some other more specific type diagnosis. Secondary review is important. We'll talk about this more in some depth in a few minutes. I think it's important in breast pathology to participate as a member of a multidisciplinary team. And it's critical that you know who your team members are, particularly the surgeons and oncologists, be able to participate in rounds. Some places have rounds for the part of the multidisciplinary case conferences from CCO for the Excision cases, but it's more problematic for the core biopsy cases, and sometimes it's difficult to organize, but it is important to know who members, if you have a breast assessment program, who they are, and be in good communication, particularly with the surgeons and the radiologists. Because you find that you may be surprised with how little information they really need from you to do what they need to do. And so sometimes we agonize over what we say, but it really doesn't mean much. So you need to know in your setting how much information do they really want. And similarly with your radiologists, it's useful to find out from them what type of question they do as part of their quality assurance, because it's reassuring, and I find it helpful in my terminology, in my reports, what I say. For example, if I have a discordant case, I'll just make a comment to add in that I would recommend final radiologic pathologic correlation. And I know that my radiologists receive my reports and they read every one of them. And if I put that in, that's a key to them to go back and take a closer look. I also know, for example, that they issue addendum reports when they see discordances, and I find that reassuring that that cases won't go discordant, or at least discordant cases will be reconciled in some way, because that's part of the standard of practice. In fact, I believe it's mandated practice for them to maintain their proficiency as a program. I would strongly recommend that within your group of pathologists that do breast, that you use consistent terminology within your group, so that everybody's saying the same thing with the same lexicon, the same nuances, and that these are understood by your clinician. Ideally with the more common, conventional, newer language that's out there, but no matter what language you use, the critical thing is that your clinicians understand what you're saying. One of my favorite terminologies is to say at least ADH, or at least something. ADH is the common one, and my radiologists or my surgeons know that when I'm saying that, there's going to be a high possibility of an upgrade to a DCIS type case. Okay, I'm going to go on hold. Cancer Care Ontario is trying to contact me. Sounds like we're having technical difficulty. I'm having to communicate by email on a separate so I'm going to continue on. I'm hoping that you hear me because I have no sound at the other end. So let's talk about some of these problematic lesions, starting with atypical ductal hyperplasia. Here are some photomicrographs of representative cases of ADH. This one here, and this is representing an area of solid pattern ADH, and here we have an example of micropapillary ADH. You can see that the entire lesion, the entire duct is not involved, but still are these little micropapillary tufts here. Here's an example in this corner of cribriform type ADH. You can see partial involvement of this ductule here. And here's one where we start to see a little bit of cytologic atypia show up in this part of the screen. So all of these lesions are ones that fall short of an unequivocal diagnosis of DCIS and but warrant excision. Now, the likelihood of upgrade to carcinoma is based on a combination of clinical and pathologic findings. On the clinical side, as we talked about, the size of the needle core is important. Whether or not it's a calcification that presented was the lesion of interest, or the mass is important. The reason being is a mass, then it's more likely to be upgraded to a carcinoma than if there are calcifications which may or may not have been completely removed by the core biopsy process. On the pathology side, there are different ways of quantifying the degree of ADH. We'll talk about this in a moment. And the histologic features of the ADH can be important. For example, if one sees, a hint of some micropapillary pattern, and that, or of perhaps a suggestion of some sort of comedo-type necrosis, then those are features that are more likely to indicate that there will be an upgrade to carcinoma. There have been a number of studies in the literature over the years in which people have tried to look at the extent of the lesion as a possible stratifier. In other words, Eli and Wagner's studies looked at 2 or fewer foci and confined to a single duct, and their experience was that none were worse at excision. In other words, they're all just ADH. So the none, if in Snage's study, 3 lobules or ducts and all microcalcs removed, then did not get upgraded to DCIS. However, there are opposite views out there. Some studies, including one by Dalton, show that it didn't matter how many foci of ADH there were. The risk of carcinoma was still the same at excision, whether or not there was 2 foci or 3 or 4 foci. Studies have looked at terminology. I think if you look at these sort of things, cannot rule out DCIS or cytologic features bordering on DCIS or ADH suspicious for DCIS. In my view, it's not surprising that these kinds of cases would have DCIS on the excision. Perhaps they were on the excision itself, on the core biopsy itself. Micropapillary architecture, we do know that micropapillary DCIS has a great incidence of being multicentric, and perhaps that's part of what's playing there. But certainly, I pay attention to micropapillary architecture and tell my surgeons as well to pay attention to that. On the logic side, the type of calcification may be important. Granular calcifications, in particular linear branching calcifications, more often than not tend to be associated with DCIS, and that's one more reason why it's useful to know what type of calcification, that information hopefully is provided to you by your radiologist. So, a lot of controversy in the literature over the years has been to try and identify whether or not there may be some patients that may not require excision, and whether it's larger gauge needles or multiple cores or determining that there's no more calcium left or just limited histology. But these remain somewhat speculative. And as far as I can see, 2015, the recommendation still remains that we should be excising these ADH lesions. There may come a time in the future when we have better quality, high-grade quality information and evidence-based information literature, which will allow us to safely not excise some patients. But if I can tell, that does not yet exist now. Move on to lobular neoplasia. Lobular neoplasia includes the spectrum from atypical lobular hyperplasia, as demonstrated on this slide, versus lobular carcinoma in situ. And this is a lesion that was basically a columnar cell lesion. I don't see the calcium here, but probably excised for calcification until found a finding of ALH there. Sometimes, of course, you can get LCIS, but the real focus we'll talk about in a minute is whether the lesion of interest is really LCIS, or was this an incidental finding in the core biopsy. And a number of studies have been done in the literature, and I just summarized a couple of them here for you. This one by Contrarian found that patients with LCIS, about 20% of them had worse lesion on excision, and 13% had a worse lesion on excision that had ALH in the core. But the trouble with this study and many others in the literature is that there's all sorts of biases that are present. For example, in this particular study, not everyone had surgical excision, so that makes you wonder, well, those that didn't, what was going on with them, and are these pre-selected cases? Similarly, the fact that some of their cases were mass lesions or had pleomorphic LCIS, well, it's small wonder that there was an upgrade rate in some of those things. One would expect that, and so those are again some limitations of this study, as well as several others like it in the literature. Also, the underestimation of ALH on core biopsy in terms of what may occur on the excision is, again, it's dependent. This is another study from Brem, and they found that if there's a radiologic mass, there's a higher likelihood of an upgrade. A higher BIRADS category would lead to a higher upgrade rate. If you use a smaller gauge needle, as we've talked about, or fewer specimens, then the chance of an upgrade is going to be high. So they suggested to perform excision in all patients. Contrarian position was this study very recently from 2013, and Chaudhry's group looked at 87 cases and found only 3 of them had upgrades in the excision, and 2 of those had previous history of breast cancer. So they thought that careful radiologic and clinical surveillance is safe in limited lesions of lobular neoplasia. But I think that the overall sort of preponderance of opinion, at least in 2015, remains that these lesions, lobular neoplasia lesions, should be excised. Now, again, I expect that there will be more controversy with this in the upcoming years, and we'll have to see where we are maybe in 3 or 4 years' time. So, recommendation, specifically there's rad path discordance, that there should be excision, but these are the minimum criteria, I think, for excision. Some people would say that all of these lesions should be excised. Papillary lesions. I think we all recognize the straightforward base papilloma, as you see here. Nice fibrovascular core lined by a single layer of epithelial cells. Sometimes you can see the myoepithelial cell layer. And when you get onto this frame here, where you get more complexity, still recognize some sort of fibrovascular core, this being an atypical papilloma or a papilloma with ADH in it, that we start to twitch a bit and wonder what else is going on. With some of these papillary carcinomas, they can be quite challenging. This top frame here is intended to represent a case of papillary DCIS in which there was no myoepithelial cell there, and cytologically the cells are very bland and monomorphous, but my top figures can be seen. Here's a case of papillary DCIS with a lot of mucin, which can give a lot of diagnostic challenges too when you have mucin in these lesions. Similarly, these are examples of solid papillary carcinoma, and this type in particular can mimic invasive carcinoma, especially on a core. These are challenging on excisions, let alone on cores, and certainly pushing margin can be seen with invasive carcinomas, and the challenge in recognizing this can be quite difficult. So if you sense that there is a sort of a fibrovascular bond in it or some sort of element of papillary core in it, these are the kinds of lesions perhaps best to call as papillary lesion, and you might give a differential or suggestion, but recommend that they come out. Diagnostic challenges, especially with limited tissue on papillary lesion, this can be a very challenging area. And so given some of the differential here already. This is a study that was published a couple years back, a meta-analysis, so 34 studies, over 2,000 patients, 346 upgraded, so a 15.7% pooled underestimation rate. So to my eye, that sounds that looks awfully high, and so this would to me to be a good reason why one should look at excising these kinds of lesions, because those are seeming kind of high numbers. The so-called benign papilloma rate, or just ordinary papillomas rate in excisions, was only 7% in their study. I would have thought it should be higher in those. So here's a study done by a surgeon, and they found that 9% of their papillomas in core biopsy were upgraded, and unfortunately we were unable to identify predictive factors based on this would help predict which patients are likely to have upgrades, and only older age, and that's very non-specific. We do know that when they're 7th, 8th, 9th decades are more likely to have cancer than not, but Rich recommended excision due to the lack of predictors for upgrade. Radial Scar. So generally speaking, when we see the full-blown lesion, these are not difficult to diagnose generally, but they typically have this sort of fibroelastotic center, and all the business end seems to be in the middle, the worrisome part of it with the hazardly trapped glands. But as you move towards the periphery of the lesion, you tend to see these more open space, benign sort of tubular structures. So that generally isn't the issue. The real question is the upgrade rate again, and it tends to be somewhat variable again. The truth is that often the cancer, if it occurs, may only occur at the periphery of the lesion. And, if your radiologist is good and he cores right through the center, you may miss that periphery. So there's been less good data for the outcomes with radial scars. So for these reasons, and the fact that these generally form part of those stellate lesions, which give most clinicians a lot of excision is really recommended for radial scar to exclude carcinoma. However, these areas are controversial. Here's a contrarian position. A study by Linda in the American Journal of Radiology showed 54 women, 2 upgrades, and they thought based on this you could observe some of these patients. That generally, it doesn't seem to be the overall view, though. Most people would say radial scar, take it out. So epithelial lesions. Here, the main issue is it fibroadenoma, cell type, or is it a benign Phyllodes tumor? I'm going to talk about the other things. I think this is the real critical one, because this is where our clinical management decision has to be made. Because fibroadenoma, clinicians may not take it out. Many of them will have a watch and wait or do nothing approach, whereas Phyllodes tumors, you need to take it out and look for margins. There are a few studies looking at what features on core biopsy might help to determine whether it's going to be a Phyllodes tumor or not. And of course, increased stromal cellularity, more draw, more atypia. These are the usual sorts of features, and not surprisingly, at least to me, these are the features that would be more likely to predict whether a Phyllodes tumor will be present or not. So with Phyllodes tumors or these lesions, I tend to sign them out as fibroepithelial lesions. See comment, and in my comment, I'll say that depending on the extent of these features, I'll say I favor Phyllodes tumor, or I'm concerned about Phyllodes tumor, but take it out. Cell lesions. So generally speaking, these we see more of because of core biopsies for calcifications, and most of these are straightforward. Columnar cell lesions are there. This one here on this side is an example of columnar cell lesion with hyperplasia. Don't cause too much trouble. The issue becomes when you get some atypia, so-called columnar cell change with atypia, or flat epithelial atypia, as some tend to call it, and flat epithelial atypia, FEA, tends to be the WHO terminology now. The thing is, it seems that a number of these FEA lesions will be something worse at excision. So generally speaking, we recommend that these be excised. The thing that is worth doing, though, on these FEA type lesions is multiple levels, because you see form or micropapillary architecture show up in this, then that bumps up to an ADH type of lesion. Mucocele-like lesions, so classic sort of case of these distended mucinous type cysts, and one doesn't know this one here is an example of mucinous carcinoma, also similar, but you really have to hunt for those small pools of mucin that may be present. Multiple deeper levels may be required to assess these sort of things, and the whole area of Mucocele-like lesions is really including a wide spectrum of pathology, from just simple mucin-filled ducts to in situ carcinomas with a lot of mucin to mucinous carcinomas in which you have these extravasated pools with very few carcinoma cells. So if we do deeper, it may be difficult to show. So these Mucocele-like lesions account for about 2% of mammographic lesions, and they usually present with suspicious microcalcifications. Again, even good quality information in the literature on these kinds of lesions, in other words, what natural history of them, what is the upgrade rate, we just don't have really good information upon which to make solid recommendations, and therefore, generally speaking, the rule of thumb is mucocele-type mucocele lesion or acellular stromal mucin. Recommend excision to rule out or invasive mucinous carcinoma. Some may turn out to be carcinomas that have mucin in them as well. A summary of those kinds of lesions for which excision is currently recommended. So these are the ones that I've covered, and they cover the spectrum of ADH, ALH, papilloma, radial scar, cellular fibroepithelial lesion, mucocele-like lesion. These are the big ones, which if you make that diagnosis or you suggest that diagnosis on your core biopsy, There's controversy with these things. I don't know that the practice is uniform across North America. I think it would certainly depend. Might have fire alarm and the just in my office, so I apologize for these technical difficulties. I just want to continue on with next slide regarding the surgical pathology report. So, really, the report should include a sufficient amount of information to permit radiologic pathologic correlation. The key here is to provide correlations. For example, if the lesion interest is microcalcification, then you must include microcalcifications identified and say where they are. For example, in columnar cell change. The real purpose of this core biopsy procedure is to get the patient into the appropriate therapeutic algorithm. For example, does the patient need simple follow-up in 6 months, for example, or perhaps an excision, or an excision with sentinel nodes if it's an invasive or microinvasive carcinoma, or perhaps go through to neoadjuvant chemotherapy. There is a lot of debate whether the pathologist should specifically recommend an excision. In my practice, I do. I will say that excisional biopsy is warranted or recommended. I know my clinicians, and they actually appreciate that information. In other centers, it depends on your clinicians, whether they appreciate having that specific recommendation in there or not. It's important to make sure that you optimize the amount of information you give. Too much can be as bad as too little. You don't want to have discordances between your core biopsy and your excisional biopsy report. As far as I'm aware, there are no mandatory electronic synoptic reports right now for core biopsies, but at least in Ontario, a predictive biomarker report as of April 1st of this year, and so even for if you do core biopsy biomarkers, then you should use that particular synoptic report. The whole role of biomarkers in core biopsies is somewhat controversial still. There is the ASCO-CAP guideline out there that says best to do it on the core biopsy, but its implementation remains somewhat haphazard, at least across Ontario and probably in other jurisdictions. In my center, and I think 2 or 3 other academic centers in Ontario that I'm aware of, we do it on the excision still. We know our tissue fixation. We're happy with it. We prefer not to have to on the core unless it's for neoadjuvant cases. But I recognize that it seems the movement is towards the core biopsy for the HER2, probably because of the 6-hour turnaround time, or rather the good formalin fixation that's available for core biopsies. But do it on the core biopsies. Make sure that you're going to do it on the excisions. It's only if you have triple negative or some sort of other reason for doing it on the excision, because you don't want to get discordant results. There are some studies that have looked at size, histologic type, and grade between core biopsy and correlation with excision. And not surprisingly, the size doesn't fare too well, but type and grade do fare fairly well. And in terms of what to report for invasive cancers, it depends. So we'll call it invasive ductal carcinoma with the grade. My practice is to say something like invasive ductal carcinoma, moderately differentiated. But some people will be more circumspect, and it's perfectly legitimate if you're not sure, if you don't have EK-adherent, you're not sure if it's ductal or lobular, to call it invasive mammary carcinoma, and perhaps have a comment to say that the final histologic typing will be determined on the excision specimen. Because if you call it ductal, it turns out to be lobular, and it's not a big deal really, but it looks as a discordance and looks bad from the clinician's eyes. So some people are a bit reluctant to do that. Use of EK-adherent again is controversial. I think it could be used judiciously. We certainly don't use it on all cases, but cases in which the morphology is somewhat ambiguous, we will do it and report results to some extent based on that, just to avoid discordances later on. Report the size or a special type, and then some people add caveats, in this limited specimen or represents a minimum size, and I think that's almost understood, but I guess clinicians don't quite get it, so it's sometimes some people feel more comfortable putting it in. I don't put that in myself, but I can understand why some people might, just to indicate that if on an excision may be some differences. To move now, getting towards the end of the formal part of the presentation, on quality assurance, and really focus on the diagnostic factors, the secondary review part, but also just to make it clear that the pre-analytic component is just so important, because specimen mix-up can and do occur, maybe in the histology lab, and maybe in the DI lab, who knows, they do occur, and we've had our share of some of these as well, and through one of our external reviews that were performed because of a specimen mix-up, there was a number of recommendations made, including a number of good ones that relate to technology. And, we do use this kind of technology for blood samples and in other parts of the lab. It seems to me that tissue core biopsy, tissue pathology is something that's been quite slow in coming on with implementing these kinds of new technologies. But I think that certainly barcode labeling, the specimen tracking, and data, computer order entry are valuable adjuncts to making sure that we have the right patient on the right specimen. Formalin time, I think that's something that everybody's aware now. The importance of 6 hours is the minimum, especially if you're going to do biomarkers. And the importance of the clinical history, really, to know that you're dealing with a palpable mass or calcification or whatever. And to know where the lesion is, because sometimes there's more than one lesion, and the surgeon takes out a different lesion. So you really need to know. I try to emphasize with our radiologists and surgeons always to tell me the clock position or the quadrant, either or, in the report. And I will include that in my final diagnosis line, just so that I have it as a reference when the excision comes, that I know what quadrant or excision it was, in case the surgeon forgets to tell me, and often the case. In post-analytical errors, one way of dealing with this is quick text, and this is not unique to breast pathology by any means, but the use of quick text that are programmed into your LIS can help you with straightforward cases. We talk about the triple test and the multidisciplinary case conferencing. It's very important in a good center to have these kinds of conferencing and correlations to avoid and to deal with some of the more difficult cases that we face. So what do you do if you report your core biopsy as malignant but there's no malignancy found? There may be two options or two possibilities. One is that malignancy is found, but it's not found, and then you have to go back and on your excisions and sample it more thoroughly, perhaps, or perhaps the lesion was completely excised by core biopsy. We do see that from time to time, and it may be important to try and reconstruct the minimum tumor size from the cores and the imaging, and report it as a minimum tumor size. Or alternatively, there's no malignancy, and it could be either a false positive in the core biopsy. Hope that's not the case, but or sometimes we've had a few cases where the surgeon has removed a different lesion or not the right lesion at all, or maybe a patient mix-up. I want to talk very briefly about secondary review in breast pathology. This is a very important initiative, not just for breast pathology, but for all areas. This particular slide shows the work that a group of Cancer Care Ontario did a couple of years back now, looking at, it was part of a series of oncologic reviews. It didn't get flies, and it's still in draft stage because for various reasons the whole program was shelved. But basically, our so-called expert panel, I hate to think of us as, quote, experts, but we are, we based our recommendations based on clinical action points. So we had a very active medical oncologist in our group, and he said, well, what are the action points for a clinician? And the ones listed here are those that we felt are important, that if you got it wrong, it would have important negative consequences for the patient. So therefore, these are the ones we chose, and as important for second review in pathology. On the other hand, we also identify cases that we don't think that secondary review is routinely required. For example, just the histologic type alone is not important, because that generally does not affect the treatment, and the final pathologic interpretation the clinicians understand will be done on the excision. And discrepancies are not reason in and of themselves for second review. These are things that should be resolved between the individual pathologist and the radiologist or the clinician, and dealt with on a case-by-case basis. Not give this presentation without at least making reference to the JAMA article, which perhaps all of you have seen. If you haven't, I'd recommend that you look at it. It's this JAMA article from March of this year on diagnostic concordance amongst breast pathologists. And unfortunately, I think it's done more harm than good for our profession. I honestly can't believe that this thing was published. It's just it's so bad. It's just such a it's got so many weaknesses. And this is some here. I mean, who in their right mind would only review one single slide per case, even if it's a core biopsy? Who in their right mind would not allow second review if it was a difficult case? So these are, and then they mixed up core biopsies and excisions. It just goes on and on. I mean, I just don't understand why this was allowed to get through. But be that as it may, it made the New York Times and a variety of other public lay forums, and so it's out there and has created more anxiety for patients about their pathology reports. On the other hand, there are a number of published studies that are much better quality, I think, that show that there actually is good concordance amongst pathologists, and this one in AJSP by Collins and group showed very good concordance. So last slide really, and I apologize for going over a little bit, but really the core biopsy should be viewed as a screening procedure, and the action threshold for moving to open biopsy should be low, especially as I've shown you that there's an absence of firm data in many of these kinds of problematic lesions on which to base management decisions. And so it comes back to, if in doubt, take it out sort of approach. And for some of these more difficult lesions, second review, use consistent terminology in your group so that your surgeons don't have to deal with one pathologist versus another, and what is it that you're trying to say. Make sure that whatever you say, your surgeons understand. I think that is the more important piece in all of this here. And if there's any doubt about the what the targeted lesion is, then it should come out. With that, I apologize for some of the technical glitches and interruptions and fire drills, fire drills, the real one. But with that, maybe if I can, I will turn it over to the moderator to begin to ask some questions and have some discussion. Can you hear me now? Now, thank you.
Minutes prior to your presentation. So unfortunately, that means nobody heard the introduction that I was giving just before the presentation. Of course, Dr. SenGupta doesn't need an introduction to the majority of the people on the call. He's well known within the pathology community, provincially, nationally, internationally. I would like to put a special mention for Dr. SenGupta's involvement in Cancer Care Ontario and the Breast Disease Site Group, and mention that he has contributed to several evidence-based series publications in breast cancer diagnosis and treatment. I also like to mention Dr. SenGupta's membership on the CBCF's research panel, and the fact that he chairs the Breast National Cancer Pathology and Staging Multidisciplinary Expert Panel for the Canadian Partnership Against Cancer. We did manage to hear your talk, so thank you very much for the presentation. It was very thoughtful and thorough. There are a few questions that came in, and I will give those in the order in which they came. So the first question came from Credit Valley Hospital, and that was, do you think it is mandatory to have pathology, radiology, correlation rounds to discuss each core biopsy? Currently, their radiologist reviews the pathology reports and issues an addendum regarding concordance or discordance, but it is the feeling that combined rounds would provide more teaching for both specialties.
Thank you for that question. I shudder a little bit when I hear mandatory, because there's many ways to skin the cat, so to speak, and I think there's many effective ways of dealing with the same quality assurance issues. So in our center, for example, we don't have mandatory rounds because it's so difficult to get radiologists and pathologists and surgeons together for those. We have tried over the years to do that. However, as I said in my presentation, I know, I do have conversations with my radiologists. I do know how they issue their addendums, and we do have forums, including multidisciplinary case conferences, which are not strictly for core biopsies, but for the cancer patient. But we do review some of these things. So I think whatever works in your center, you should attempt to do. I wouldn't want to have anything as so-called mandatory, but there may be other ways to deal with it. And I think the key thing is a combination of formal and informal type of communication processes. So I think the work by Stuart Schnitt, Boston group, are good. And rather than try to go through in a detailed fashion, I would recommend that you review Stuart Schnitt's work on FEA. But basically, FEA is a lesion in which you see significant atypia. And the trouble, of course, as you know, is that it's the eye of the beholder and somewhat subjective. I would recommend you review some photos of those kinds of lesions, and it's and I show it around. These are difficult lesions, and I know I get a lot of my colleagues showing me these cases because they're not comfortable with either. I would recommend that what them is I do deeper levels. I will make sure that there is no ADH present. And if I'm happy with that, then I just take it out.
One is, what management recommendations for atypical upper metaplasia and core needle biopsy? And then the second has to do with columnar lesions associated with upfront change. And how do you assess that for
atypical apocrine lesions? I think there's a spectrum of apocrine lesions, which I didn't get into. So get everything from the usual sort of run-of-the-mill apocrine metaplasia, which are part of fibrocystic change and cysts, and we see those a dime a dozen. Actually, that's and I just report those as fibrocystic change. Now, atypia in apocrine lesions really refers to probably nuclear size. Now, you have to see significant increase in nuclear size to diagnose atypia in these kind of lesions. So, because they do tend to be, they all look atypical some way. But if you see atypia in those lesions, then they have to be handled as they need an excision. They may not turn out to be cancer. Some of them turn out to be something, maybe just atypical apocrine adenosis or something to that effect, but they need an excision. As I said, really, the management goal is a low threshold for excision. I mean, we're not quite at the refinement yet where we can say these you can watch, these you cannot. But I think they do need some, probably some second review and consensus within the group, and then run an excision if it's that. Second part of the question with respect, I think it had something to do with columnar cell change. Again, really, if it's just columnar cell change or columnar cell change with hyperplasia, I think sort of speaking falls into the rubric of fibrocystic change, and those patients can be followed. I don't have a problem even in saying that. It's when there's columnar cell change, hyperplasia, and atypia, or so-called FEA, that one needs an excision. And really, I find those lesions not that difficult to pick up in the sense that at low magnification, they kind of remind me of endometrial, proliferative endometrium. I don't know, that's maybe a funny analogy, but I find that that's the case. And those kind of lesions that I see look like that at low power, I take a closer look at it, high magnification.
The next question comes from Holton here. How far do you go to find calcifications in a core biopsy when there's none? Or small to account for, too small on the biopsy to account for the radiologic calcification? Do you block, lift the tissue, cut level?
All of. So yes, we would X-ray the blocks, and I turn the block on edge as well if I see something to how deep it is in the block, because sometimes you can cut and you don't see anything, you cut some more, and maybe right at the bottom of the block. So you put it on edge, and there's calcium there. And if I don't see any calcium on the imaging, then I just do a set of deeper levels just anyway, because sometimes, for whatever reason, they don't even show up on the imaging faxitron or deck that we use. The other thing, of course, is have you polarized? I mean, the standard thing we teach our residents, you got to polarize all the cases because some of them are calcium oxalate and not calcium phosphate. Some people state which type of calcium it is. I don't go to that level of detail because I don't think the clinician cares. But I will polarize them. And then, as I said, there are some cases, as you said, the type of calcification is too fine to correlate with that. And then you just have to say at the end of the day, you've done your job, you've done your due diligence, you hand it back to the radiologist in your report and say, there's discordance here, you may need to rebiopsy or take a look at this again.
Next question has to do with biomarker testing biopsies. Is in a multi-site institution, specimens from some sites do not meet cold ischemic time requirements. Would you recommend doing biomarker testing on those cores?
Probably yes. I think, as I said, the trend, starting with the ASCO-CAP guidelines, really is to do it on the cores. And for various reasons, some of us don't. There's some issues of funding and how would you fund if you have to do HER2 and reflex testing and all this sort of stuff. There's the issues of double counting and, there's those sorts of issues. But in general, I think that core biopsy tissue is really well fixed. I mean, you got to make sure that it's the minimum 6 hours. So, in the late afternoon, I wouldn't start, if you put on a tissue processor and doesn't get that 6 hours, then I think markers may be problematic, although in my opinion, these things are pretty robust markers, although there too is something a bit tricky. I think, so in that setting, if you can't, you get that sort of 1 hour sort of cold ischemic time down, and you may decide, well, maybe we're going to do it on the cores. And the most important thing really is what's best for the patient, what's going to give the best quality result.
Question on secondary review. Is the mandatory second pathologist review for a new malignancy?
I see no reason for that. I think that's, all of us are trained to do breast pathology, and it's most cases of invasive carcinoma or DCIS are fairly straightforward, and I guess it depends on your practice pattern. And where I'm practicing, we have 2 dedicated breast pathologists and 2 others who do a bit of breast pathology. And so, and we're subspecialized. So, I mean, we see enough cancers that we feel comfortable with the straightforward run-of-the-mill stuff, and don't feel that warrants second review. Said that, we do have a list for every one of our subspecialty disciplines of mandatory second review. Primary diagnosis of malignancy is not one of them, but cellular epithelial lesions might be one of them, sort of thing. So, depends on your practice. If you're in a general community practice and you don't see a lot of primary breast pathology, maybe it should be. You have to assess community as academic and even the community, how much do you see and that sort of thing, I think.
Okay. Next question has to do with microglandular adenosis. That is, what is your recommendation for microglandular adenosis? Do you run the excision?
Should come out because all these may be MGA with atypias. The whole area of microglandular adenosis, even out atypia and carcinomas, and that is a funny lesion that not a huge amount of literature on, and these kinds of things I don't think one institution, even with the bigger ones, have a lot of experience, so these things need to come out and be properly evaluated.
Next question. Your opinion on the DIN classification system. as opposed to classification as ADH?
DIN, I don't like it. I've heard Dr. Tavasoli at many seminars. I've gone to some, and I understand it, but I don't like it. I don't like it because our clinicians don't understand it, and I don't want to convince them. Our clinicians understand ADH and DCIS, and as I said in my presentation, the most important thing is communication with your clinicians. If they understand DIN, I don't have a problem with it, but I wouldn't use it.
Question. We have had a few cases of ER negative, PR positive, with an outside lab. With those cases, is there a role for tamoxifen, in which are ER negative, PR positive?
They exist. I get a few of them. My understanding from the literature is that they're approximately 4% or less. Some people say that ER negative, PR positive represents dysfunctionality at the molecular level. I don't know the details of that at the molecular level, but we do see them. And usually the PR in those cases is a weak PR. It's not strong PR. If you get strong PR, then you've got a technical problem, because a strong PR should not be associated with an absent ER. In my experience, there's usually weak PR. And so, my clinicians will always come back to me, the oncologist, and say, well, you screwed up, test it again, do this and that. And if I'm doing it on the core, I'd be tempted to repeat on the excision, just because it's an unusual setting. I'd recognize that it is that. Clinicians will treat for that, although my understanding from my oncologist is that those patients don't do well on tamoxifen, but that's a decision that they have to make.
All right. That is a submitted question. I did have one question, and that has to do with role in chemistry for biopsy, distinguishing DCIS or ADH. How do you use immunohistochemistry and a particular cocktail that you use?
I'm a minimalist. I don't use a lot of immunohistochemistry except in certain instances. I will use smooth muscle medicine, heavy chain, and P63 in trying to ascertain how much of a lesion is DCIS versus invasive or not. Some problematic tubular lesions, I sometimes just need a little comfort factor before I hit the trigger and call it cancer. And so I want to see the lack of a myoepithelial cell. Generally, I don't do myoepithelial cell markers routinely. There is variation in our group practice. Some of our junior colleagues seem to order it on everything. I think it's a waste of money. I do E-cadherin on ambiguous lesions morphologically that sort of an intermediate grade. You sort of see a little bit of Indian filing, and the only reason I do that is because I prefer, if possible, to classify it as ductal or lobular. But in some instances, if I don't think I can get the immune back in time and I need to get the case signed out, I'll just sign it as invasive mammary carcinoma and say that the permanence will, or rather the excision will be used for the definitive assessment. And then there's the other big area is for spindle cell lesions, in which you want to rule out spindle cell metaplastic carcinoma and the like. You need P63 and a variety of keratin markers and so forth. I think, histochemistry and breast and breast pathology is a whole talk in itself, but those are the key ones that I would suggest.
The question comes in. Do you recommend excision for a typical African adenosis?
I think it's a difficult diagnosis to make on a core biopsy, but if I saw it, I would say yes. And as I said, that's one of mine that you have a low threshold for excision, and it just could be associated on excision with DCIS, rather than just Atypia. So Atypia of generally any type, atypical, ductal, atypical lobular, atypical apocrine. I think those lesions need to come out.
And there's no more submitted questions. I just want to thank you for your participation in our review, which had to do with secondary review on breast cancer. I want to mention that those documents were repurposed as evidence summaries, and they're available at the CCO website in a finalized form. But it's important that they're set up as evidence summaries for additional work, and are not official recommendations for the pathology lab medicine program.
I think good to hear, because there's a lot of excellent information in terms of overall review of the literature that's embedded in those documents.
So on behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I thank Dr. SenGupta for a truly comprehensive, informative, and a clear presentation today. This is the sixth and final session of the 2015 series of CAT checklist presentations. Welcome comments and suggestions to inform these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluation. The WebEx recording of this presentation becomes available. It will be available for wide distribution via links posted by Cancer Care Ontario, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. A reminder, both the live and recorded presentations are eligible for continuing education credits. Please see the notes for more information. The CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. Sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notes for the exact deadline date. Thank you to everybody for participating today.